This recording will give you an introduction to hypertension and also discuss diuretics and beta blockers. So what is hypertension? Hypertension is elevated blood pressures, and the kidney plays an important role in maintaining blood pressure. You're familiar from A&P, the renin-angiotensin-aldosterone system plays a role in maintaining blood pressure. And if you're a little rusty on the renin-angiotensin-aldosterone system, you'll want to review it and get familiar with it again, because some of the medications we talk about will interfere with this normal system that the body's using. So like right here, we have ACE inhibitors interfering with the renin-angiotensin system to help decrease blood pressure. So just to break down this system in simple terms. So for renin to be secreted by the kidney, is the body condition going to be a low blood pressure, low blood volume condition, or a high blood pressure, high blood volume condition? So what condition in the body causes renin to be secreted by the kidneys? And if you are guessing that low blood pressure, low blood volume is what causes renin to be secreted by the kidneys, you're correct. So when the kidneys detect that they're not getting the blood that they need, the kidneys secrete renin, which causes a chain of reactions that ends up with angiotensin II and aldosterone being created. Angiotensin II helps to increase blood pressure because it's a potent vasoconstrictor, and aldosterone helps to increase blood pressure because it causes sodium and water retention. So it's helping us hold on to fluids, both of which lead to increased blood pressure, right? So normally, when the renin-angiotensin system is doing its thing, it leads to increased blood pressure. We have medications like ACE inhibitors that interfere with this normal process to help keep blood pressure low. So again, if you're a little rusty on that system, please review it so that you can understand how these medications work to help lower blood pressure. Physiologic risk factors include a diet high in saturated fat and simple carbs, alcohol, and obesity. Normal weight loss can decrease hypertension, as can mild to moderate sodium restrictions. African Americans are more likely to develop hypertension at an earlier age than Caucasians. African Americans are susceptible to low renin hypertension and therefore do not respond well to beta blockers and ACE inhibitors. The antihypertensive drugs that are effective for African Americans are alpha-1 blockers and calcium channel blockers. African American patients do not respond to diuretics as the initial monotherapy, so mono being one, the one drug given, for controlling hypertension. These cultural differences you do need to be familiar with. So again, African Americans do not respond well to beta blockers, ACE inhibitors, or diuretics as monotherapy. Yes, they do respond well to alpha-1 blockers and calcium channel blockers. Asian Americans are twice as sensitive as Caucasians to beta blockers and other hypertensives. A reduction in antihypertensive dosing is frequently needed. So for Asian Americans, the dose that they're taking versus a Caucasian person may be lower because they have an increased response to the medication. Native Americans have a reduced or lower response to beta blockers compared with Caucasians. Monitoring blood pressure and drug dosing should be an ongoing assessment for patients in these cultural groups. One of the troublesome side effects of the use of antihypertensive agents in older adults, especially frail or institutionalized persons, is orthostatic or postural hypotension. This episode of sudden low blood pressure presents as dizziness due to blood pooling in the lower extremities when an individual changes to an upright position. In older adults, the sympathetic nervous system does not respond as quickly to correct the situation, especially when potentiated by antihypertensive drug administration. If orthostatic hypotension occurs, the antihypertensive drug dose may need to be decreased, or another antihypertensive drug may need to be used. Older adults with hypertension should be instructed to modify their lifestyles and activities. This could also be applied to other people. Teaching includes restricting dietary sodium to 2,400 milligrams daily, avoiding tobacco, modifying diet, exercising, and decreasing stress. So with the older adults and in general, with these antihypertensive drugs, the safety concern that we have for our patients is orthostatic hypotension, right? Leading to syncopal episodes where our patient might fall and hurt themselves. So with all of these medications, any medication that's lowering blood pressure, we're definitely going to be worried about orthostatic hypotension and our patient's safety. And we've talked about some of these non-pharmacological controls of hypertension, and we'd want to include that in patient teaching. And here are the guidelines for determining hypertension. These are the numbers that you'd want to be familiar with. You can review those on your own. So diuretics are not a new classification of medication for you. So when you think of diuretics, you should think of diuresis, right? They're causing the patient to urinate, to take off some of the fluid that is in their system. So diuretics help to lower blood pressure by decreasing the amount of total fluid that's in the patient's blood vessels, right? So if less fluid is flowing through those blood vessels, there's less pressure pushing against them. Hydrochlorothiazide is the most frequently prescribed diuretic for controlling mild hypertension by decreasing excess fluid volume. Many antihypertensive drugs can cause fluid retention. Therefore, diuretics are often administered together with antihypertensive agents. If you look at box 39.1, it has a list of combinations of thiazides with antihypertensives and other combinations. And you don't need to memorize all those, but what I want you to recognize is that hydrochlorothiazide is frequently combined with other medications, and that's because they, one, help to bring down blood pressure because they're diuretic, and two, they can counteract any sort of side effect of the other medication if it has a side effect of fluid retention. Thiazide diuretics are not recommended for patients with renal insufficiency. The loop diuretics, such as furosemide, are usually recommended because they do not depress renal blood flow. We're going to briefly go over beta blockers because this is not the first time that we've talked about them, so you should be familiar with them. You can review on your own if you need a little review. So beta blockers or beta adrenergic blockers are used as antihypertensive drugs or in combination with a diuretic. Beta blockers we talked about before as being anti-anginos or anti-dysrhythmics. We talked about them when we talked about the adrenergic drugs, so this isn't the first time that you're hearing about them. Beta adrenergic blockers reduce cardiac output, so that's reducing the amount of fluid traveling through those vessels, by diminishing the sympathetic nervous system response to decrease basosympathetic tone. So we're turning down sympathetic system. With continued use of beta blockers, vascular resistance is diminished and blood pressure is lowered. Beta blockers also reduce heart rate. Remember, a lot of people initially, they know that beta blockers are going to lower my blood pressure, but we have to remember it's also going to lower heart rate or pulse. Beta blockers reduce contractility and also reduce renin release. African American hypertensive patients do not respond well to beta blockers alone for control of hypertension. If an African American is receiving a beta blocker, it's usually going to be combined with a diuretic to make it effective. Then we go on to talk about non-selective versus selective beta blockers. So those cardioselective beta blockers are selective to the beta-1 receptor. And that means bronchoconstriction is less likely to occur with those cardioselective beta blockers. This is important for our patients who have respiratory issues, and we don't want that bronchoconstriction for those patients with respiratory issues. That can also alleviate sometimes side effects that are not necessary for the patient if they're only taking it for a cardiac related reason. And as we talked about before, you can remember, or a way to help remember which drugs are which beta blockers are cardioselective. Think of ABE and ME, or ABE and ME, based on your charts that you have in your textbook for beta blockers. If it's starting with an A, a B, or an E, as well as metoprolol being the ME, metoprolol, those are your cardioselective beta blockers. And it's important that you can recognize those and know that your patients with respiratory issues are going to benefit from a cardioselective beta blocker. In terms of side effects, again, this isn't the first time we're talking about beta blockers. I'll highlight a couple things. So decreased pulse rate, decreased blood pressure. So the hypotension, we're worried about safety and falls and syncopal episodes. The non-selective beta blockers can cause bronchospasm. Beta blockers should not be abruptly discontinued because rebound hypertension, angina, dysrhythmias, and MI can occur. Non-selective beta blockers inhibit the liver's ability to convert glycogen to glucose in response to hypoglycemia. Because of the side effect, beta blockers should be used with caution in patients with diabetes mellitus. In addition, bradycardia is a very common adverse effect of beta blockers. Your textbook has a purple nursing process box on beta blockers that's full of great information. Since this is a review for you, I'm going to let you review that on your own. But again, please do review it. Take notes of what's important there. It has a lot of great information in those purple nursing process boxes.